Hi, CTO team and friends. Welcome back to the channel. Today, another core curriculum talk. We are continuing our series on CTO PCI safety based on the global safety recommendations of CTO PCI consensus document. So the topic for this talk is hemodynamic collapse during CTO PCI. Now, this is obviously a huge topic, and not only is not possible to do it in one video, it's not even possible to do it in one paper. And so really this point 4 in the paper, is really only the most important CTO PCI hemodynamic collapses, and it's not really meant to be a grand survey of all the causes. So we mentioned specific causes which we think are common or important or easily correctable or are important in CTO PCI. So the first one we mentioned is the access site bleeding, retroperitoneal bleeding. So I think we managed to get a consensus that all femoral access should be obtained by using ultrasound and fluoroscopic guided techniques. So the ultrasound, of course, makes sure that you get into the center of the vessel, and fluoroscopic guidance makes sure that you're above the bifurcation. And in this case, you sort of minimize the risk of access site bleeding. Access site bleeding, in my experience, is quite frustrating because you're doing a CTO PCI and the procedure is long and the patient starts getting lower and lower blood pressure, and you try to, now it's easy if you see a big hematoma, you feel it, but that's frustrating because then the only way you can stop the hematoma is to press on the access site while you keep doing it. And obviously if you have somebody pressing on the access site, that's quite frustrating for a first operator because he gets in the way. And if you're pressing on it, then you're one hand less, and it's not easy to do. So access site still causes a problem with completing the CTO PCI. So it is best to use good access site techniques such as ultrasound and such as fluoroscopic guidance so that we can actually minimize access site bleeding. The use of ultrasound can reduce the risk of access site complication, is well documented. The second thing we mentioned is aortic insufficiency due to guiding. So commonly it's thought the AL1 guidings, AL2 guidings, where you deep-seated press on the aortic valve and causes AR and hypotension. Particularly common in low position right coronary arteries. But it can also occur with EBU types guiding, especially you're using a longer EBU4 or an XB4 and you deep-seated, that can cause AR. This is something to be worth recognized early because it's quite easy to solve. I mean, your fluoroscopy, you see the guiding is dipped down, you put it back up, the blood pressure comes back up. And obviously this can also, if you don't recognize it, can obviously kill the patient. So very important for CTO PCI. Number 3 is ischemia. Ischemia during CTO PCI can cause hypotension, especially the retrograde ischemia. And this is specific to CTO PCI because usually you don't engage the other vessel when you do PCI. And the retrograde PCI, of course, the guiding damping on the retrograde side, or you have a dissection of the guiding os, or you have thrombosis, air embolism, or closure of the donor artery. Those all can cause a drop in blood pressure. In patients who have a baseline low ejection fraction, we need to be careful because those patients tend to not tolerate retrograde procedures very well. The hypotension from retrograde can also come from retrograde channel pressure. So if you push a lot of pressure on the retrograde channel by pushing a microcatheter across or pushing a CTO wire against the CTO through retrograde channel, that can actually billow out the LV and cause hypotension as well. So in patients with low ejection fraction, there should be a preference of using antegrade technique. So if you can do the CTO with antegrade technique, you should try to do that first. The use of ventricular support device such as impeller is important. Limiting the contrast volume is important. Contrast is not good for the LV. So when you have a patient who's got a dodgy LV and you're doing a retrograde, then limiting the contrast is important. Reducing the ischemia time. So very often the retrograde channel is a big channel and supplies significant blood to the CTO territory. And if you occlude this for a long time, or there's tortuosity and you cause poor flow, then that could cause ischemia and worsening of the hypotension. So all of those things we need to be aware of. Donor vessel lesions, number 4. If you have a donor vessel lesion and you cross that lesion, you're going to cause the donor territory to have ischemia. And of course, if there are more collaterals coming off distal to that lesion to your CTO territory, you're also going to get CTO territory ischemia. So it's very important to treat donor vessel lesions, both for the prevention of thrombosis during retrograde and also for prevention of distal donor vessel or distal collateral ischemia. The other problem with donor vessel is the donor vessel ischemia. Donor vessel ischemia is usually caused by tortuosity in the donor vessel, especially epicardial collaterals, and the accordion effect of passing a microcatheter across the donor collateral. Sometimes administration of vasodilators like nitroglycerin can resolve the spasm and can help, but this is particularly problematic if you're using the lemur as a retrograde donor vessel, because the lemur usually is quite tortuous, and by the time you pass a microcatheter through the lemur, you get lemur ischemia to the LAD. So if you're using the lemur to go to distal LAD through a distal LAD septal to RCA CTO, that's something that we need to be very aware of. We've done that a few times with impeller support to mitigate the hypotension, but it's best to try to minimize the time you spend. And if the lemur is very tortuous and you're getting no flow through it, then you need to reconsider an alternative method to do the CTO. Of course, number 6 is perforations. Perforations can cause hypotension, of course, especially when it causes tamponade, and we need to be on the watch out for perforation. So often, if we are worried, we ask for an echo just to check that there's no tamponade while we're doing the case, especially if we know the wire has gone outside the vessel architecture. Anaphylaxis, usually in relation to contrast, is something we need to be aware of. This is usually the silent one, because very often we don't get any clues. We don't see a guiding that's deep-seated into the aortic cuffs. We don't see a perforation, and we don't feel a hematoma in the groin. So anaphylaxis is something that we need to keep at the back of our mind and treat that as needed. So these are the only ones we've listed in the document. Of course, there are many other causes of shock during CTO PCI, but we think these are the important ones for us to grasp hold of when we're doing CTO PCI. So I hope this talk is useful, and that when we come to that frustrating moment when we're doing CTO PCI and the blood pressure is low, we can go through these ideas and try to sort it out. So usually for me, I quite quickly go to what I suspect is the main problem. And there are things that are really worth checking early, like the guiding causing AR is one that's almost, it takes 2 seconds to check. The groin takes a couple of seconds to check. So those things I will check quite quickly. And the donor artery, again, takes 1 shot, takes a couple of seconds to check. So those 3 or 4 things I tend to check quite quickly, and within a minute to have felt the groin, looked at the guiding position, checked on the donor vessel. So if those are all okay, then we start thinking, what are the other causes? So this sort of trying to get these major problems eliminated within the first minute is quite important to dealing with this. So I hope you have good luck and you don't get hypotension in your CTO PCI, but when you do, I hope this talk helps you. If you like, do press the like button and do subscribe to the channel for other talks on safety of CTO PCI. We'll see you next time. Bye-bye.